management question. I normally avoid using anticoagulation at least for 2 weeks after an acute stroke. And I know some physicians actually differ in that, but my understanding of the literature is that there is no evidence generally that treating with anticoagulation within those first 2 weeks actually makes any long-term difference. So the situations I'm talking about is a new stroke with atrial fibrillation, a new stroke with LV thrombus. I would probably just treat with aspirin first. I mean, what's your view on that?
Yeah, so yet another Pandora's box, but let me see if I can answer. The data about the MI within the first week was after the MI,
right,
in people that didn't have stroke. Okay, just to be clear. So then the question becomes anticoagulation and a recent stroke. And there is good data at the HASTE trial, HAEST, which evaluated the risk of recurrent stroke versus the risk of hemorrhagic transformation. What it found was the risk in the first couple of weeks of a recurrent stroke after you've already had a stroke from AFib is like 0.5%. The risk of hemorrhagic transformation if you use heparin in that setting is 11%. So it was a huge difference in favor of using antiplatelets in the early setting. Now, then you start getting into how big is the stroke, how old is the patient, what are their comorbidities, but in general, and centers differ. I know Mass General is very aggressive in using a lot of heparin early on in the acute hospitalization, but many of the stroke neurologists that I know tend to wait, and the residents are always frustrated with me because they say, well, how long are you going to wait? And I look at the scan, I look at the patient, I say, 2 weeks, and the next case I say, 4 weeks, and they're like, what? I'm just making these numbers up. I mean, nobody really knows the right time to wait, but the risk of hemorrhagic transformation is real, and it can make a huge difference in their outcome. And what you're trying to offset is the risk of recurrent stroke. Cardiologists all the time are calling you as neurology consultants and saying AFib equals heparin, and you're like, no, wait, they just had a stroke. They did it. They already threw their thrombus, so let's let their brain recover before you start anticoagulating. So many times I will have them on aspirin when they're in the hospital, wait a couple of weeks, and then often we'll start Coumadin without the bridging heparin, which is something that our hematologists don't like. With the exception of in the stroke in the young patients, if I'm concerned that they could have something like a protein S or protein C deficiency that Dr. Mackey was discussing, those patients are the ones that get Coumadin skin necrosis, because they get transiently hypercoagulable. So the young patients that I'm starting on Coumadin, I often will use bridging like a low molecular weight heparin or IV heparin. But the older 65-year-old patient with a moderate to large stroke from AFib, I'll wait 2 to 4 weeks and then start oral Coumadin as an outpatient.
Okay, that's really helpful. Just if I can just outline a recent case that I came across. So it was a youngish patient, actually. I think he was 30, 35, and he had atrial fibrillation at the time of his found at the time of his stroke. The physician on call had started him on I think heparin. Because of the atrial fibrillation and the high risk. I then came in the next day and stopped it and put him on aspirin with the view to do an echocardiogram and so on and so forth. And then I went away on holiday, as often happens, and when I came back, it turned out that this chap on his echo had a large LV thrombus. Yeah. So, in hindsight, I still feel that I did the right thing, but I think, another physician could criticize that management. What do you think of that?
Yeah, I think that's going to be extraordinarily uncommon, especially in a 35-year-old. Yeah. I mean, I would be thinking about like the thyrotoxicosis or other things I wouldn't have thought without the history to look for an LV thrombus. But I think in general the risk is, so sometimes you have to take into account if they're in our hospital, we don't get echoes on the weekend, so they're coming in on Friday, and you won't get an echo until Monday afternoon. What are you going to do about that? And I probably still would not heparinize that patient.
Okay.
The exception might be if they have a teeny tiny little cortical stroke, and I think that their risk from that stroke is very, very small. Okay. Or if they're having recurrent events. I've had some people with these flurries of events kind of everywhere, and then I'm doing everything I can with anticoagulation. But in general, unless it's a very, very small infarct, I'm probably going to recommend antiplatelet and for at least a couple of weeks. And then if they already have some hemorrhage, which, by the way, if you get an MRI on most strokes nowadays, there's some petechial staining on MRI. So, but if they have on CT some hemorrhagic transformation, then how long do you wait, and do you ever? Right. And I usually say if they have AFib, they do need it, but I'm going to wait longer. Right. I'm going to say 4 weeks or 6 weeks or some number that's random.
Okay, thank you. That's reassuring.
Thanks. right, any other questions for some of our previous speakers? We still have Dr. Kurth and Dr. Mackey here. Anybody else have questions for the group?